Good afternoon, everyone, and welcome to the HealthHIV Transform webinar. I'm so happy that we're doing this, glad that you all are participating, and Happy New Year to each of you if we haven't said Happy New Year yet. I am Dana Cropper-Williams, Director of Education at HealthHIV, and as many of you know, HealthHIV is a national nonprofit that provides capacity building, health services research and evaluation, advocacy, along with education and training in HIV, HCV, and LGBT health. We also lead two coalitions, which are the National Coalition for LGBT Health and the Positively Healthy Coalition. Today's webinar is in accordance with our Thrive Transform program purpose, which is to support your health departments and collaboratives to develop comprehensive models of prevention, care, behavioral health, and social service models for MSM of color that are living with or at risk of HIV acquisition. We are delighted to present this webinar. The webinar is entitled Cultural Competence, Building Our Knowledge and Understanding of the Social and Cultural Context of Men Who Have Sex with Men of Color in Service Delivery. If you have not already completed your HPAT form, please do so and send it to ryan@healthhiv.org by Friday. And as you all know, this is a way for us to keep track of our technical assistance efforts. As you know, cultural competency training is probably the most requested topic area of the Thrive program, and we see cultural competency as the foundation of the Transform curriculum. We are happy that our partner, the National Black Justice Coalition, will present this information today. During this webinar, you can use the chat box to share thoughts or ask questions, and you can also use the raise your hand icon, all that you'll see on the left hand of your screen. At the end of this webinar, we will have a question and answer session, which will be facilitated by my colleague, Antonio Williams, and he'll ask you to submit information in the chat box and your questions. There is also a slide where you can download the PowerPoint right here at the bottom. There's a document icon, and if you click on that, the PowerPoint of this webinar will download, and you can have that at your disposal for later. Once again, this webinar is Cultural Competence, Building Our Knowledge and Understanding of the Social and Cultural Context of Men Who Have Sex with Men of Color in Service Delivery. We're very pleased that our partner is facilitating this and presenting this good information to us today. Partners the National Black Justice Coalition, and we had the honor of having the Executive Director do this presentation today, and her name is Sharon Letman-Hicks. This webinar will be an introduction to cultural competency work moving forward, because we really do see this as the framework for addressing the needs of MSM of color in your jurisdictions. So now I'll turn it over to you, Sharon. Thank you.
Thank you, Dana. I am very excited to be a part of this conversation today as a starting point for cultural competency. As you can see, the name of the webinar is Cultural Competence, Building Our Knowledge and Understanding of the Social and Cultural Context of Men Who Have Sex with Men of Color in Service Delivery. I am a very direct presenter, and I want to make sure that every possible question that you could have, that you put it together. Even though this is an introduction, I hope we have a robust Q&A. So, to get us started, I want to make sure we understand the learning objectives. We're going to discuss the social and cultural climate of men who have sex with men of color, including the impact of stigma. Stigma will be heavily covered during this webinar. We're going to examine foundations of cultural competence, identify effective strategies from individual and system levels for engaging MSM of color, and explore action continuum for increased cultural competence. So who are we talking about today? It is very important for all of us to have a foundation on who your client is, who is the customer base here. Black and Latino MSM live at the intersections of multiple social identities. Because of this reality, their experiences are complex and informed by each of their historically marginalized identities. There's no singular experience for Black and Latino MSM, but they do share some similarities because of larger social processes. Understanding that complexity is the work for service providers in becoming more culturally competent and meeting the needs of Black and Latino MSM of color. I can't stress that enough. As we move into the process of exploring cultural competence, it is critical that we begin to increase our knowledge of the populations that we are trying to serve. Increasing our knowledge is a critical component to becoming more culturally competent, and it also grounds us in the why of our work. Toward the end of the presentation, we will discuss more of the how with naming of strategies and exploring cultural competence framework. And both of these slides just give you some highlighted points that I'm sure you're all aware of, but to really understand the severity. One thing that I always stress when I'm doing cultural competency is to highlight the fact that Black MSMs and Latino MSMs are also Black men and Latino men. So the same systemic issues from a cultural identity or based on race, they are layered with as they navigate in this world and society. So the MSM of color and health. We need to be very clear on key factors in this conversation. MSM of color experience discrimination when accessing health care. MSM of color distrust their providers because they experience discrimination when accessing health care. And MSM of color have worse health outcomes due to distrust in the healthcare system. But I'm going to take it a step further. If you look at the healthcare system and racial minorities, especially African American men, are at the highest level of every health disparity there is. So again, layering it as a sexual minority, it will not be a surprise that Black MSM living with HIV experience stigma from healthcare providers, which was associated with longer gaps in time since last HIV care appointment. Some of these factors on this particular slide are also due to the reality that prior to, the last decade, it was just stigmatized to be out. It was stigmatized to declare your sexual identity, and society drove that disparity that is now what we have to realize has to be overcome for the many layers of LGBT equality that's going on in society. So we're going to talk a little bit about the social and cultural factors impacting quality of life for MSM of color. As I just alluded to, there are social determinants of health for the LGBTQ population. The federal government, especially over the last 8 years, was very intentional of bringing an identity to the LGBTQ population. That's the lesbian, gay, bisexual, transgender, and queer population. So it is very important for you to be in line as service providers with the way of what many agencies had to undergo in understanding the LGBTQ population. So these are the social determinants of health for the population. Keep in mind several factors will overlap with MSM of color social determinants as African Americans and Latinos. lack of LGBT cultural competence along with the lack of racial cultural competence, and in many instances, immigration statuses, create a traumatic, underserved, and disengaged population. Your work will involve being competent in all of the areas above and more. A picture will be painted about how MSM of color have dealt with many of these realities most of their lives while living as a man of color in this country. The internal oppression that many MSM of color suffer from is as critical as the external factors suppressing their value in society. And just as this slide demonstrates, homelessness, lack of legal recognition, poverty, anti-LGBT bias and discrimination, racism and other social discrimination, and lack of insurance coverage and lack of LGBT cultural competence, layered with the many other issues that are going on in the LGBTQ population, particularly things like religious exemption that are potentially going to be legislated, leads to LGBT health disparities. So we're here, we're going to focus on the types of discussions that will be had during this webinar. Around social determinants of health, we're going to take into factors of birthplace, how you live, how you learn, how you work, how you play, how you worship, your age, that all weigh into the factors of the quality of life outcomes and your risk factor. These are universal factors that are to be taken into consideration when evaluating someone's health risk and quality of life. We'll explore how MSM of color are challenged by their intersectional realities of being a racial ethnic minority and a sexual minority. You will hear that a lot throughout this presentation and during the cultural competency path, because many times you expect somebody to walk in your door, you service them, and they leave. But the health disparities are so atrocious with this population, you have to go a step further. You have to recognize that there are social determinants that are creating this disparity amongst this population. So we're going to be very intentional about how do we make connections with you as a service provider on reaching out to the housing authorities, public safety, emergency health care, and you really being on the front lines of being an educator within your public health department and the community on how to bring the needed resources to offset these social determinants. Now, looking specifically from an African American lens, social factors influencing HIV transmission in the Black community, although behaviors that put people at a high risk of contracting HIV, such as unsafe, unprotected sex, sex without a condom, and intravenous drug use with an infected needle, are individual decisions. But it's important for us to also consider and address the issues that drive and influence these choices. In other words, what are the unique factors that adversely impact the health of the Black community, especially MSM of color? Oftentimes, especially dealing with MSM of color, you have an investment in your Blackness and or your cultural and ethnic background, and you have an investment, especially with the current era of LGBT equality, in owning your power, owning your right to be out and accepted. So when you have to navigate those two, you never should be in a position that you have to check your Blackness or your cultural identity, or you could only live as an LGBT person. You should not otherwise a population. So by virtue of that, there's been some great studies that break down these factors, including racism, socioeconomic status, mass incarceration, social location or place, stigma, access to care and treatment, and media influence. Now, it's interesting because the real conversation also has to be homonegativity. There's reality that many people who identify as gay, lesbian, bisexual, transgender, or queer have been condemned, rejected, humiliated, isolated, or ostracized to many places, including their home, their school, their place of worship, their workplace. When communities display fear, anger, or stigma toward the LGBTQ community overtly or in silence, this may lead to these individuals to feel rejected and live their lives in secrecy. This often leads MSM of color to feelings of shame and guilt about who they are and their value in society, which subsequently can lead to engaging in high-risk behaviors. And then there's trauma. There's a whole nother set of challenges for MSM of color, because intimate partner violence, what does that look like? In most societies, people only envision it as men and women, but two men could be engaged in an intimate partner violence, and law enforcement will look the other way. Sexual assault and community-related violence all increase the risk factor for HIV transmission. And additionally, the mental health consequences of trauma, such as depression and post-traumatic stress syndromes and disorder, can make it challenging to engage in self-care or self-protective strategies. Trauma diminishes the sense of self-worth, increases depression, and contributes to decisions to engage in drug use, as well as other behaviors that place us at risk for contracting HIV. Now, the loaded six-letter word, stigma. Stigma, the word stigma is stigmatizing. Many men who have sex with men are particularly vulnerable to HIV as well as to other physical and psychological health concerns. MSM of color experience multi-layered stigma and discrimination as a result of their perceived or real HIV status, their sex, their same-sex behavior, and their race and or ethnicity. Because of social and cultural non-acceptance of their sexuality and fear of being ridiculed, MSM of color experience internalized stigma, which manifests as guilt, depression, lack of confidence, and unwillingness to discuss their sexual lives. This not only influences their mental health, but also combined with enacted or perceived stigma by healthcare providers can impede the utilization of health services by MSM of color. And I want you to envision the level of stigma that many MSM of color start with. It takes a lot of courage for someone to come out, especially in their household. Imagine coming out to your family, particularly your mother, and the first reaction is, are you HIV positive? So many times people have to debut twice in coming out. Debut first as coming out as being gay, and then living with the perceived assumption that they may be HIV positive, which may preclude them from ever getting tested properly or already feeling the backlash, and then having the debut as HIV positive. So causes of HIV stigma and discrimination, there are key stereotypes that are central to homophobia, gender ideology, and racism, and classism. There, you know, the MSM of color community is the spectrum of economic wealth, economic advantages and disadvantages, and there is ongoing stereotypes that white gay men walk in privilege and people don't even see MSM of color. And none of those, all of those are stereotypes. And the reality is, but we walk with that heaviness as a community when you think about how do you overcome these stereotypes and causes of HIV stigma and discrimination. So let's look at a conceptual model. Stigma happens when others devalue a person or a group of people because they are associated with a certain disease, behavior, or practice. And like a 1-2 punch, those who are stigmatized often experience discrimination in some fashion. The effects of both can be even worse for groups who already are marginalized because of their gender, sexuality, ethnicity, or substance abuse. Those who stigmatize people living with HIV falsely believe that the virus is highly contagious and that they could easily become infected. When that happens, others start to view HIV-positive people as a threat. Many become isolated within their homes, in public, at their workplaces. They are further stigmatized by others' assumptions about their moral integrity, such as the belief that they became infected with HIV because they chose to take part in risky behaviors. And in many instances, MSM of color are held to a different moral standard than others and often are disproportionately blamed for HIV in their communities. In the end, stigma and discrimination continues to undermine prevention, treatment, and care for people living with HIV and AIDS. It hinders those with the virus from telling their partners about their status. It threatens their access to health care. It increases their vulnerability to physical violence. And HIV-related stigma affects people's ability to earn a living, making it even more difficult for them to lift themselves out of poverty. So the impact of stigma on health outcomes of MSM of color, the World Health Organization cites that fear of stigma and discrimination as the main reason why people are reluctant to get tested, disclose their HIV status, and take antiretroviral drugs. An unwillingness to take an HIV test means that more people are diagnosed late when the virus may have already progressed to AIDS. This makes treatment less effective, increasing the likelihood of transmitted HIV to others and causing early death. Excuse me, I'm having challenges navigating. So, causes of HIV-related stigma in health facilities, just in the big picture, is lack of awareness among healthcare workers of what stigma looks like and why it is damaging. Fear of casual contact stemming from incomplete knowledge about HIV transition, association of HIV with improper or immoral behavior, and assumptions about client based on their HIV status. Now, this is where you come in. All four of these, you could step back from an objective lens and say a person that is even involved with this type of stigma shouldn't be working in health facilities. But the reality is that those people exist. And we hope that through these levels of training that people will get a better understanding of the population that they've been entrusted to serve. But more importantly, you have to look at yourself in talking about cultural competence. How are you open? How have you dealt with your isms and bias to go deeper in the exercise of cultural competency? So prominent social and cultural drivers of health disparities for MSM of color. At the end of the day, issues of racism, sexism, homophobia, institutional and structural racism impacts all of us. And from the position of service provider, if we are not mindful, we produce social inequality in healthcare through perpetuating our racist, sexist assumptions, conscious or unconscious assumptions and stereotypes. And again, this is not labeling anyone. This is focusing on the root cause of these stereotypes. And it is the cumulative impact of those attitudes, behaviors, and beliefs that either allow Black and Latinos to feel safe and supported or further traumatized as they seek to engage care. Because of the overt challenges of racism, sexism, and heterosexism, you in many ways as a direct service provider have a lot of power to move this population into a space of dignity, into a space of trust, into a space of healing, so that the self-worth that patient has, a lot of that power is in your hands that provides a greater service to society. So I threw out a loaded word, bias, interpreting provider bias, cultural competence as intervention for effective engagement of MSM of color. It is so important that the role that service providers play is 100% critical. It is so important for us to understand that the service provider plays the role that you play is so critical. Thinking about cultural competence in this context suggests that is a form of intervention not only prepares you as providers to be more effective at engaging diverse populations, but also invites you to interpret systems of oppression that are impacting the overall well-being of Black and Latino MSM. So let's dig deeper a little bit on bias. Implicit bias. This is worth reading out loud. Implicit bias refers to the attitudes or stereotypes that affect our understanding, action, and decisions in an unconscious manner. These biases, which encompass both favorable and unfavorable assessment, are activated involuntarily and without an individual's awareness or intentional control. And I'm going to give you a real-life, unrelated situation. Many of us that grew up in sports households, you automatically had a team that was assigned to you in your household. And that team has nothing to do with anything else in your life other than that is your team. And everything else is secondary. So in that case, you have an implicit bias against all of the teams because it was ingrained in you at a certain point in your growth and development that there is no other team but that team. That's how I don't want you to feel that bias is such a bad word. It's just sometimes just the way it is. But whether you can grow out of that bias, probably not with your sports teams, but if you can grow out of your bias in the workplace, this is some of the things, these are some of the traits we want to bring to your attention that come with implicit bias. Here are 10 ways implicit bias operates. Selective attention. We tend to selectively see some things but not others depending on the context. For example, pregnant women are more likely to notice other pregnant women. Diagnosis bias. The propensity to label people, places, and things based on our first impression, irrespective of evidence that put before us. Pattern recognition. The tendency to sort information based on prior experience. Pattern recognition. The tendency to sort information based on prior experience. That's just like, Black men walking in a hoodie. If you had an experience where someone feels that if you're wearing a hoodie, then you must be up to no good, is usually based on some type of bias from a previous experience. Value attribution. The inclination to infuse a person or thing with certain qualities based on initial perceived value. You judge someone's importance based on what they are wearing. Groupthink. The influence of group associations and beliefs on our thoughts and behaviors. We all know the days of groupthink when we were teenagers in high school and how opinions are formed. That is a type of bias. Confirmation bias, the tendency to unconsciously seek out evidence to confirm what we believe is true. The tendency to unconsciously seek out evidence to confirm what we believe is true. Not evidence-based, what we believe to be true. Priming effect, the implicit tendency to respond to something based on expectations created by a previous experience or association. The implicit tendency to respond to someone based on expectations created by a previous experience or association. A very dangerous one, priming effect. Commitment confirmation, the tendency to become attached to a particular point of view, even when it may be obviously wrong. Stereotype threat, the experience of anxiety or concern in a situation where a person has the potential to confirm a negative stereotype about their social group. And anchoring bias, the common tendency to rely too heavily on one trait or piece of information when making decisions, such as assuming that people from elite schools are more qualified despite holes in the elite school graduate's credentials. So this is a snapshot of 10 ways implicit bias operates. So charting a course for providing culturally competent services. The role that service providers play, again, is 100% critical. Thinking about cultural competence in this context suggests that it is a form of intervention not only prepares you as providers to be more effective at engaging diverse populations, but also invites you to interrupt systems of oppression that are impacting the overall well-being of Black and Latino MSM. So let me say that a little more clear. You have the power to chart a course for providing cultural competence services and helping to identify ways that the client, the patient, needs to, that you can open up that are systems of oppression or self-oppression that can aid someone in taking better care of themselves and getting on the care continuum. So let's define cultural competence. Let's make sure that we are clear that it takes time, it takes practice, and it takes self-reflection. Cultural competence is not an end goal, but a commitment to an ongoing engagement with welcoming and affirming behaviors, knowledge, attitudes, and policies. It is so important that we understand that the repetition, the practice, the self-evaluation, the training, the retraining, the continued training is how you get to understand a population, respect a population, lift up a population. I want to emphasize that this is a process of evolution and a commitment to think beyond what you know and what makes you comfortable. This is about really being a servant leader that you could step outside of yourself and what you know and open up yourself to a whole nother world that you may have robbed yourself of. I can say as an LGBTQ advocate and someone that's deeply invested in the Black community and the Latino community, my journey of not only gaining cultural competence but also teaching cultural competence was not an overnight process. So this is not something for you to feel like this is just too much for me to take on. This is about embracing, understanding, being a better service provider, and having the sensitivity, the patience, and the wherewithal to expose yourself in a very vulnerable way to meet someone where they're at, for you to know how to ask for better understanding, get clarity as to what that person needs from you in order to help them help themselves. Time, practice, and self-reflection. So the cultural competence road to success looks like this. As I stated already, it takes time. Some people, unfortunately, start at the cultural destructiveness level, using one's power to eliminate the culture of another. When we, an example, it was something that happened recently in North Carolina, the exclusion laws. When we redistrict, we can get rid of that neighborhood. If we could get rid of the special needs students, our scores would improve. That's cultural destructiveness. That's where we have no intention of being inclusive. We have no sensitivity to make sure all is treated equal, all is included. Cultural incapacity, a lack of capacity to help children and families of color. No conscious intent to be culturally destructive, but practices may be discriminatory or paternalistic. So it's important that cultural incapacity oftentimes is really the same level, but unconscious as cultural destructiveness. Cultural blindness, intended philosophy of being unbiased, embracing idea of we are all the same. Race and culture are not considered, and there is no truly individual approach to treatment and treatment planning. I have to stop there because cultural blindness is we're all the same. We're not all the same. Okay? As a cultural competency trainer, we are not all the same. People come from different backgrounds. People come from different economic statuses. People come from abusive backgrounds. People get abused along the way. Some people suffer from mental health illnesses. Some people have addictions. We are not all the same. So the unique thing as a service provider of any level is understanding your customer base, in your case, your client base. And it's very important that we get rid of that. Why do we have to have this special treatment? Then this is not special treatment. This means you weren't treating effectively. So if the numbers are so skewed and there's so much disparity, that means that the method of service providing needs to change. You can't just assume that a community is so unwilling to do something when you're only approaching them and servicing them from a very monolithic lens. So cultural bias, that's what cultural blindness means, that you walk in an era that we are all the same. Cultural pre-competence, recognition of limitations of service and staffing with effort to improve. There may be tokenism. If there is not representative leadership, that's the language that I use, that the facility that is servicing a community, especially a community that has overrepresentation in your service place, if the community is not represented in that space, then that's a red flag from a cultural competency, because people want to see themselves in the facilities. They want to see the right posters on the wall. They want to see the right literatures on the wall. They want to know that you see them. So in many ways, a combination of representative leadership in the workplace as well as the proper marketing tools that represent a community is very critical to the pathway of cultural pre-competence. And not just, that I have that one black friend. Not that mentality, that's tokenism, but actually having the competency to understand and to represent a community in a way that they feel seen, they feel heard, they feel serviced. Cultural competence, acceptance and respect for differences, commitment to incorporate new knowledge to better meet the changing needs of minority populations. At advanced stage, you will be training others soon. Your knowledge, empathy, respect, and understanding will be developed. And cultural proficiency, you are there. You are ready not only to be a better service provider, but to teach others how to become culturally proficient. The differences are valued and seen as strength. Continual efforts to augment knowledge and improve practices. The most advanced stage, your skills will include understanding elements of culture from different lenses and not being fearful of speaking up or addressing inequalities. That is what a true advocate is supposed to look like on any issue. But a true advocate that can speak about a population, regardless of being represented, and not feeling like, well, if there's an MSM of color that works in your office, that's his responsibility to deal with this, and this in quotes, this community. That is absolutely the wrong mentality. People should not only advocate for themselves. None of us have only advocated on our own behalf or people that we represent and be a culturally competent service provider. So, deconstructing a little bit more. We just went over a deep dive on cultural destructiveness. And here are a few more examples. Assumption that one's race is superior and should eradicate lesser cultures. That's a real hurtful one. Cultural incapacity, giving a deeper lens and refresher on what I just went over with you. Oppressed by enforcing racist policies and stereotypes. Employment practices are discriminatory. Cultural blindness, just to recap some of the areas I just covered, people view themselves as unbiased because they feel we should all look at each other as the same. Cultural pre-competence, organizations who use the check-the-box method of achieving cultural competence. And cultural competence. We're getting closer, but we got a little bit more work to do. And then cultural proficiency. So I wanted you to hear my words, and then I wanted you to see the words. I feel the energy on this call for our Q&A that's up and coming. And we have national standards for culturally and linguistically appropriate services in health and healthcare. The standards are a blueprint for individuals and health and healthcare organizations to implement culturally and linguistically appropriate services. So principal standards provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Governance, leadership, and the workforce. Advance and sustain organizational governance and leadership that promote class and health equity through policy, practices, and allocated resources. And CLAS, as you can see, is the culturally and linguistically appropriate services. Recruit, promote, and support a culturally and linguistically diverse governance, leadership, and workforce that are responsive to the population in the service area. And educate and train governance, leadership, and the workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. And communication and language assistance, offer language assistance to individuals who have limited English proficiency and or other communications needs at no cost to them to facilitate timely access to all health care and services. Inform all individuals of the availability of language assistance services clearly and in preferred language, both verbally and in writing. Ensure the competence of individuals providing language assistance, recognizing that the use of untrained individuals and or minors as interpreters should be avoided. And provide easy to understand print and multimedia materials and signage in the languages commonly used by the population in the service area. I felt it was important to go over each point as you read along so we can really understand how do we meet the national CLAS standards and what are certain things that you can even look at this and write down yourself to say, we are not doing this. We are not meeting this standard. We have got to work on this particular area. So the purpose of the national culturally and linguistically appropriate services standards is key. Okay, let's transition to that level of understanding. The national standards of culturally and linguistically appropriate services in health and healthcare are intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services. Adoption of these standards will help advance better health and healthcare in the United States. So this is a universal standard if you all want to take it to the next level. And the intersection here is advance health equity, help eliminate disparities, and improve quality of services. Now, what does that actually look like? I love this slide because people often confuse equality with equity. And equality is when all people are delivered services in the exact same way. Equity is when all are given enough to achieve the same outcome. Here, the height of the different people does not represent the ability of people, meaning the shorter person is not inferior to the taller person. The height represents the different level of structural barriers that different people experience. The taller person is more privileged and does not experience many structural barriers to care. The shorter person has fewer privileges and experiences more structural barriers. The fifth represents a health outcome. For our purposes, it could represent preventing HIV. When health services are delivered equally, not everyone will reach the health outcome. When health services are delivered equitably, the health outcome can be achieved. When all pictured people are able to see over the fence. Oh, I love this slide. What we should draw from this figure is that MSM of color simply have more risk factors, not that they are inferior. Given their increased risk, it is essential that services, social and clinical, be targeted and accessible for MSM of color more so than other populations that have less risk. Let me say that again. What we should draw from this figure is that MSM of color simply have more risk factors, not that they are inferior. Given their increased risk, it is essential that services, social and clinical, be targeted and accessible for MSM of color more so than other populations that have less risk. And let me tell you what that looks like. One of the biggest issues that people don't realize with the overrepresentation of HIV, particularly in the African American community, African Americans are less than 15% of the population. And Black MSM have a tendency to stay within their race and relationships. So the pool is smaller. So the opportunity for the infection rate where it is at this point is much greater because we only surround ourselves in a particular area. There's been increased studies that Black people, Black LGBTQ people, particularly Black MSMs, live where Black people live. So as a smaller population, we don't live in what people assume are the neighborhoods and the Chelseas of the world. We live amongst the Black population. So you're already layered with oppression as a racial minority, and you're also ostracized because you are an MSM of color. Your frequency and your surrounding and the self-oppression, you're also staying in one smaller bubble with a greater opportunity to be at risk. That's how you have to look at when people say that there are additional needs. You have to understand the social circumstances, the dynamics in which our community lives. So the pathway to cultural competence. The role that service providers play, as I've stated over and over again, is extremely critical. Thinking about cultural competence in this context suggests that there is a form of intervention that not only prepares you as a provider to be more effective at engaging diverse populations, but also invites you to interpret systems of oppression that are impacting the overall well-being of Black and Latino MSM. So as we go into pathways for cultural competence, we have to deconstruct the building blocks of how to become culturally competent. You have to have cultural awareness, cultural knowledge, cultural sensitivity, cultural humility. Well, what does that look like? So cultural awareness is defined as the process of conducting a self-examination of one's own biases towards other cultures and the in-depth exploration of one's cultural and professional background. Cultural awareness also involves being aware of the existence of documented racism and other isms in health care delivery. Cultural knowledge is defined as the process in which the healthcare professional seeks and obtains a sound educational base about culturally diverse groups. Cultural competence is the demonstrated awareness and integration of three population-specific issues: health-related beliefs and cultural values, disease incidence and prevalence, and treatment efficacy. But perhaps the most significant aspect of this concept is the inclusion and integration of the three areas that are usually considered separately when they are considered at all. Cultural sensitivity is defined as the ability to be appropriately responsive to the attitudes, feelings, or circumstances of groups of people that share a common and distinctive racial, national, religious, linguistic, or cultural heritage. It is characterized by two components: cultural encounters and cultural desire. Cultural encounters is a process which encourages the healthcare professional to directly engage in face-to-face cultural interactions and other type of encounters with clients from culturally diverse backgrounds in order to modify existing beliefs about a cultural group and to prevent possible stereotypes. And cultural desire is the motivation of the healthcare professional to want to engage in the process of becoming culturally aware, culturally knowledgeable, culturally skillful, and seeking cultural encounters, not the have to. Cultural encounters is the pivotal construct of cultural competence that provides the energy, source, and foundation for one's journey towards cultural competence. There will be a lot of adaptation required in the workplace in order to build a culturally sound environment and also to demonstrate your cultural desire. And cultural humility. Cultural humility, the full fruit of cultural competence. Some people prefer the term cultural humility instead of cultural competence. Sometimes cultural competence seems to suggest that you can learn everything to know about another person's culture and experience without ever having experienced it. Cultural humility is similar to cultural sensitivity, but specifically refers to an attitude and disposition that is a permanent state of respect. Cultural humility can be specifically crucial when working with clients with intersectional identities. We know that all people who identify as Black and or LGBTQ spectrum express those two identities in a multitude of ways and providers that cannot assume those expressions. Cultural humility on behalf of the provider can help allow for this complexity of expression and intersectionality of identities to be respected for each client they encounter. So I want to give you a example of cultural humility. All day long in my life, I'm an LGBT advocate, and it is my community. I speak of we because it's my people. But I never get so comfortable that I don't exercise cultural humility. So you may see a client, particularly an MSM of color, they may talk amongst each other, and they may call each other Judy, or they may refer to themselves as a queen. That does not give you the license, because you are friendly with the community, that you can adapt their language and their culture and expect it to be universal. You may get so close to a client that you have your own lingo, but you may get confused and use that same lingo with a stranger that comes in the door, expecting them to receive your friendliness because you believe you're culturally competent. That's culturally insensitive. That's where cultural humility has to come into place. There's no universal anything for any people. There are black people that don't want to be called African American. Most of us don't want to be called Negro anymore, and we damn sure don't want to be called colored. So you cannot. Somebody may have that affection to someone else, and they have their own lingo, and they have their own way of expression. You never cross that line with cultural humility. You never allow that to work in a workplace. You can get hit up against a brick wall for that sensitivity. And I know advocates who are all day doing the same type of work that I'm doing, and then in their social environment, they feel more relaxed because they have gained cultural acceptance in their small circle. So you don't get up on stage and use that comfortability in any way, shape, or form in mixed company. I suggest that people don't use it at all, because that is part of the exercise of cultural humility. There are certain things you just don't do, especially when you're not a part of the community, and especially not in the workplace. So that's a form of that cultural humility, that you always respect people for what you have been trained to understand is your role, and don't cross that line. That sensitivity, show with care, show with excellent service, show with respect for the population. So some strategies for effectively engaging MSM of color. Because the issues impacting Black and Latino MSM are complex, there are many strategies that you as service providers can deploy to more effectively engage the population. These strategies can be at the individual level as well as the institutional level and structural level. Cultural competence is one strategy that helps us as individuals to be better service providers, and also has implications on our role in changing systems. So what does that look like? This is a model of cultural awareness, from engagement to respect to communicate to understanding. Once you have achieved an understanding of cultural competence, you will need to use the steps above as a daily basis. Excuse me. Approach the MSM of color client with respect. Communicate openly and effectively. Understand the population and social determinants. Don't assume them. Understand them, especially meet the person where they're at. Engage fully to give the best support and client care. The client will receive your respect and communication effort, and trust will be developed over time. Trust will be developed over time. Another way of looking at it, provider continuum of action. Your work, building capacity and creating safer spaces for MSM of color through cultural competence. Your work, being an ally, the action continuum. From the data, we see that some MSM of color have challenging encounters with healthcare providers. Therefore, this action continuum is offered as a helpful starting place to gauge our own level of participation within systems that perpetuate racism, sexism, heterosexism, and homophobia against Black and Latino MSM. Actively participating, telling oppressive jokes and offensive jokes about MSM of color, verbal or physical harassment. Denying, enabling oppression by denying MSM of color are oppressed or experience racism, sexism, heterosexism, or homophobia. Does not actively oppress, but by denying that oppression exists, actively participating in maintaining dynamics that keep MSM out of care. Recognizing no action is aware of oppressive actions by self or others and their harmful effects, but taking no action to stop this behavior. This inaction is the result of fear, lack of information, confusion about what to do, experiences discomfort at the contradiction between awareness and action. That's probably one of the worst because it's so invisible. It's kind of like the bullying concept and doing nothing but seeing it because you don't feel like you're equipped to handle the situation. Step in. You can handle any, because if you have the foundation of what respect is, you have the ability to step in and minimize the damage. So supporting oppression to confronting oppression. Recognizing with action is being aware of oppression, recognizing oppressive action of others and taking action to stop it. Oppressive action of self and others and taking action to stop it. Educating self, taking action to learn more about the impact of oppression of MSM of color and how it contributes to MSM of color health disparities by reading, attending workshops, seminars like this webinar, cultural events, participating in discussion, attending social action and change events. Now I'll go a step further. There is so much that goes on with LGBT equality that you should also understand how the laws of the land have changed. You should not assume that someone comes in and needs an HIV test or is HIV positive and they're not in a healthy relationship. You should not assume that they're not married. Marriage equality is the law of the land. So becoming more educated and being sensitive and reaching out to someone with a half full message instead of a half empty message, it should really be a part of your own self-education. Educating others, moving beyond only educating self to questions and dialogue with others too, rather than only stopping oppressive comments or behaviors, also engaging people in discussion to share why you object to a comment or action. The why is extremely critical to grow a community of culturally competent people. Supporting and encouraging, supporting others who speak out against oppression, homophobia, racism, sexism, heterosexism, or who are working to be more inclusive of the MSM of color community. And initiating and preventing, working to change individual and institutional actions and policies that discriminate against Black and Latino MSM of color, planning educational programs and or events, working for passage of legislation that protect MSM of color from discrimination, being explicit about making sure MSM of color members are full participants in organizations or groups. That's what initiating and preventing looks like. So, how stigma manifests in healthcare settings. Stigma starts at the front door. And this is how you can look at yourself as providing quality service. Location, proximity to other places. At the institutional level, we know that provider bias and stigma starts for Black MSM as soon as they enter your space. How have you trained every level of your department with impact the service of MSM of color, down to the person at the front desk, whether it's a receptionist, whether it's an intern, whether it's the direct provider themselves? How have you trained every level of your department will impact the service that MSM of color receives? That person walks in and they may be too flamboyant. A snicker is completely inappropriate. You may have stigmatized that person, they may turn right back around and walk out the door, or you might get rid. So how you train every level of your department will impact the service of an MSM of color. Recognize how lack of provider awareness and bias can impact MSM of color. From the front desk, to the volunteers, to partner networks, online resource materials, provider-patient relationship, personal beliefs of providers in healthcare settings based on race and or sexuality. And a few key strategies to effectively engage MSM of color who seek care. Raise awareness about stigma and understanding. Raise awareness about stigma and understanding the negative consequences of HIV stigma for patients. Create opportunities for staff volunteers to be trained in order to understand the social inequities MSM of color face as a subpopulation, not just LGBTQ subpopulation, and also racial and ethnic minority subpopulation. It is very, and I talked about this at the very early part, no one should have to check their race or their sexuality at the door. You have to receive the population as Black MSM and Latino MSM as a unique, distinct population that has unique, distinct needs in order to reach them to maximize care, and develop models to improve provider-patient relationship in order to establish that real understanding. Just like I said, are you in a relationship versus how did you get it? Are you married? These are things that you have to become more sensitive, just as if you were talking to someone in a heterosexual relationship, to not only determine their risk status, but to also show them some respect as to that they are not just what you may have once perceived or base it on stereotypes. And it gives people the warmth when you come with positive questions or questions of affirmation for them to feel comfortable to open up to you more as a service provider. So as we come to a close, we need to chart a course. We need to be able to build from this conversation, this introductory conversation, to realize a future without HIV. We must ensure prevention efforts reach all populations equitably, to reach all populations equitably. And break down barriers to care and treatment is one of the most important things we can do to end the HIV epidemic among MSM of color. And I thank you so much for your time, and I'm going to turn it back over to HealthHIV.
Thank you so much, Sharon, for this wonderful presentation. At this time, we're going to open up the floor for any questions that may need to be addressed at this time. If you have any questions, please feel free to type them in the chat box, and we will go through them and address each and every one of them. Again, are there any questions at this time?
Thank you,
and Ethan, you are welcome. Seeing that there are no questions at this time, we want to again thank Ms. Sharon Littman-Hicks, Executive Director of the National Black Justice Coalition, for presenting this wonderful webinar. As stated earlier, please by Friday, February the 3rd, please fill out your HPAC forms and submit them to Ryan Meyer at ryan@healthhiv.org. In the future, if you need have any TA needs, please feel free to reach out to us here at HealthHIV, and we'll be glad to make that work for you. Also, fill out the evaluation that is also sent to you after this presentation. Seeing that there are no other questions, again, we thank you all for coming to this webinar, and we also thank you, Sharon. Say that again, I'm sorry.
Antonio, I believe Nicole has a question, and thank you, Jackie. That would be a question for HealthHIV.
Nicole, I do see your message. We will follow up with you regarding your message. Do we get a certificate? Are there any other questions? As we can see, Ryan just entered in the SurveyMonkey to do the evaluation. You may complete the evaluation at this time. If not, if there are no other questions, again, we thank you all for attending. We thank you, Sharon, for doing your presentation, and you all have a great afternoon. Thank you.